Well, hello everybody and welcome to the March 2024 edition of the European Urology Podcast. My name is Declan Murphy, urologist here in Melbourne. I'll also be joined shortly by my co-host, Joyce Bard, urologist in Amsterdam. So coming up on this edition of the European Urology Podcast, we're featuring two of our selected papers from this month's edition of the world's leading urology journal. One of these is focusing on prostate cancer screening, specifically in men aged 50 or thereabouts, a really interesting experience from Sweden. We'll be hearing from lead author Ola Bratt from Gothenburg, and we'll also be joined by one of our associate editors, Gianluca Giannarini, who also handled that paper for the journal. Following that, we've got a very interesting systematic review on node-positive penile cancer. We don't feature penile cancer very often in this journal, so it's really good to feature a rare disease such as penile cancer. We're joined by Ashwin Sachdeva from Manchester, who led that systematic review, and also by another of our associate editors, Sarah Sutka from Seattle, who handled that paper. And Sarah will stay on later on for a bit of a chat about her role at European Urology and a bit about her day job at the Fred Hutch Cancer Centre in Seattle. We'll also be hearing from Eduardo Felicia, urology trainee in Portugal, who's going to cover our What Else Caught Our Eye in the Journal this month section. But first of all, let's cross over to Joyce, who is speaking to Ola and Gianluca about this prostate cancer paper.
So, it's my pleasure to welcome our first two guests for this month's episode of our podcast. We're going to talk about prostate cancer screening. And for this, we have invited Professor Dr. Ola Bratt. He has published a great paper on population-based organized prostate cancer testing. And these are the results from the first invitation of 50-year-old men in Sweden. And Professor Dr. Ola Bratt, he is urologist and professor of clinical cancer epidemiology at the University of Gothenburg in Sweden. And he's also the chairman of the Swedish National Working Group for Organized Prostate Cancer Testing. So a very warm welcome to you, Ola, and thank you for being here today.
Thank you, Joyce and Declan, and of course, thank you for inviting me.
Yes, and of course, congratulations on this great work.
Thank
and
you.
Our second guest for today is, actually also the associate editor and who handled this paper for the European Urology. So we have Dr. Gianluca Giannarini, fellowship-trained uro-oncological surgeon working at University Hospital in Udine in Italy. And he's also the chair of the dissemination committee of the EAU guidelines. So welcome to you, Gianluca.
Thank you very much, Joyce, and thank you, Declan. And it's a pleasure to be with you, and of course, to discuss the paper with Professor Bratt.
Great. So first to you, Ola. Prostate cancer screening is already there in Sweden from 2020, if I understand it correctly. So could you briefly summarize this study for us and just highlight the key findings of your study?
Yes, of course. As the title clearly says, we just report the outcomes of the first invitation for the regional population-based programs for organized prostate cancer testing or screening, if you wish. We invited all 68,000 men in the three most populated regions in Sweden, actually covering half of the Swedish population. And reported what happened. And what did happen was that 1/3 of the men, 35%, accepted the offer after they had a letter with a brief explanation of the pros and cons of testing. And we report the number of men with a positive PSA over 3. All of those men had an MRI. The outcome of the MRI, the different Pirate score, the outcome of biopsy. I can just briefly mention that 2/3 of the men with a raised PSA above 3 had an MRI, and after that, no biopsy. So MRI was very effective to rule out a need for biopsy. and of course the cancers we detected and the treatments the men received. And the most important findings, I would say, is actually, number one, it worked. So the European Union recommends since December 2022 that we should evaluate the feasibility of population-based screening. And yes, it is feasible in a Swedish context with the infrastructure that we've built with administrative IT system, national register, OPT offices managing the letters and all. So that's one. And the second was rather a surprise, maybe a bit embarrassing, but we hadn't realized the importance of using different PSA assays. So because all men were 50 years old, one would expect that the proportion of men with a raised PSA over 3 would be similar, very similar in all 3 regions. But it was actually a difference between 2.3% in one region and 4% in another. Those are small numbers, but that means that in the region with 4%, on a relative basis, they needed to do more than 70% more MRI scans. And since we're talking population-based screening, that is a lot. So I'll stop there. That, I think, is a summary.
Great, thank you. So, Gianluca, you handled this paper for the European Urology. What were your thoughts when you reviewed this paper?
Yeah, so I really would like to congratulate Professor Bratt and all his co-workers for this study. So the OPT is already famous. And so this is a very good typical and very good example of a modern program of organized population-based organized prostate cancer screening. So we have to acknowledge that prostate cancer screening is really a very, very hot topic and is kind of living a second life, at least in Europe. And this is, as Professor Bratt alluded to, in large part due to this milestone recommendation of the European Council. So I would like to emphasize this. And so the European Council, after nearly 20 years of silence, came up with this recommendation and recommended the nations of the European Union to evaluate the feasibility and effectiveness of a modern organized prostate cancer screening, because we have learned over the years and over the pivotal trials many things. So we will try not to do the same mistakes. And I think one further point is that we as urologists have to be proud of this, because this was made possible largely to the efforts made by our society, the European Urological Association, who provided the European Council a strategy of a modern risk stratified or risk adapted personalized screening based on PSA and MRI and other stratification factors. So this, I think, and so the OPT is really one of these trials. So exciting times ahead, but now it's time for the questions. So we have really many questions, Ola. So I will start, and again, a clarification. So there are so many famous trials for prostate cancer screening coming from Sweden. So the Gothenburg, the Stockholm 3, and others. So is Sweden offering, or has Sweden implemented a nationwide screening program or not? Or maybe local or region-wide. So can you please clarify, and what is the background of this OPT study?
That is a very relevant question, Gianluca, and thank you for the kind introduction, and actually also for accepting the paper, of course, in European Urology, the window of urology in the world, I would say. Do we have a national screening program for prostate cancer in Sweden? The answer is no. The national authorities evaluated a national screening program and recommended in 2018 against a screening program, just like almost all other national healthcare authorities around the world. So the regions are the ones who actually provide the healthcare, the tax-financed public healthcare. And they were concerned about the ineffective, socio-economically unequal and very resource-demanding unorganized PSA testing. So basically they were saying, okay, so you don't want us to have a national screening program, but we have to do something about it. So this is a pragmatic solution to organize the unorganized testing, to make it more effective, to make it more equal. At least all men will have the same opportunity to weigh the pros and the cons and decide for themselves whether to get tested or not. And also that we can gain knowledge. The widespread unorganized testing, it's just a lot of PSAs that's being done. We learn basically nothing. But since we enter all the diagnostic results into a register and we strictly follow an algorithm, we can evaluate what we are doing and contribute to science and a future screening program. So that is the answer. So it's very screening-like, but it's regional projects or programs that is a pragmatic solution to a problem.
Yeah, great. Yeah. So, I mean, I'm trying to touch the most important point. So, for example, the age to start screening. So there's a lot of debate. You know, for example, the other smart screening program, the ProBase in Germany, they started at the age of 45. So you choose the 50. Why did you choose this age? And I mean, we expect, of course, a higher incidence of prostate cancer in older men. What is the reason behind?
Certainly also a good question. Of course, if we invited 60, 70-year-old men, we would detect more cancer. But an analysis from the Gothenburg 1 screening trial shows that to be effective, screening has to be initiated at the age of about 50 to 55 years, maybe 56, 57, who really know. But that's one reason. We wanted to start early. The program would be from 50 to 74, and it seems logical to start with the younger ages. That's one reason. The other reason is that we also wanted to test the feasibility of a quite advanced infrastructure. And we didn't want to put pressure on the urology and radiology services by detecting lots of cancer. I mean, we are inviting tens and thousands of men. And if we'd invited 70-year-old men, the system would have drowned in men with a raised PSA, the numbers of MRIs needed. Of course, we'll get there in the end, but we have to realize that population-based screening is a huge enterprise, and we have to make a stepwise implementation.
I fully agree with you. I think this is one of the most important points. So, I mean, foreseeing all the consequences of the age of stars that are, of course, on a population-wide basis are really crucial. So the second is, so what are the urologists doing? So are they risk stratifying patients? Are they even performing DRE? We recently read some papers, and probably DRE in the setting of screening is obsolete. What are your thoughts?
Yeah, so the algorithm, we try to make the urologist and to follow the algorithm very strictly. And we've got a philosophy in the Organised prostate cancer testing program in Sweden that we should let men remain men as long as possible. And we've been inspiration from mammography screening. Well, women, they get invited to a mammogram, and if that's okay, they just got to get a letter, so it's fine. So men with a raised PSA, they have an MRI scan. They don't see a urologist. Seeing a urologist makes you a patient. They have an MRI scan, and if that's fine, they just receive a letter, so MRI was fine, we'll invite you again to a new PSA after 2 years. So, of course, for those men who have an indication for biopsy, which is set by, of course, PIRIS 4 and 5 means biopsy, and also PIRIS 1 to 3 with a high PSA density. The cutoff was, when we did the study, 0.15. Now we changed it a bit. So the men who have a biopsy, we strictly inform the urologist when to biopsy, how to biopsy, and how to follow up. Most men go back to the algorithm, a new PSA after 2 years. We don't want individual follow-up in urology clinics, new PSA after 3 months, maybe repeat biopsy, new PSA after 6 months. We want to streamline it in a way that would work for the entire population of 1.5 million men in Sweden.
Right. So the third point is MRI. So my first comment is, of course, that we don't have so many data on the performance of MRI in so young individuals, not patients, individuals. So how was your experience or the experience of the radiologists who were involved in the study? And second point, of course, most trials now are using the biparametric MRI. So can we state that biparametric MRI is the gold standard of prostate cancer screening compared to the current gold standard multiparametric MRI?
Well, I'll start with the second question. I would say yes. Biparametric MRI without the contrast injection is the gold standard for screening purposes. There will be reported a randomized trial at the EAU meeting in a month exactly, and the results are still pending. But even if multiparametric MRI turns out to be slightly better, I would say that for screening purposes, we can do a biparametric MRI in 8 minutes with contrast injections. The patient will be there, or the man will be there for maybe 40 minutes. And again, if we are going to perform tens and thousands of MRI scans in Sweden per year, it's very important to make it short. So I think that's pretty clear for screening purposes.
Okay.
And your first question, now I've forgotten that one.
No, it's again the performance of the MRI in young individuals. So we don't have that many data. So is it performing good as we know for 60 or 65 gentlemen, or no?
The experience is much smaller in younger men. I think, of course, the ProBase trial in Germany has provided lots of experience, showing that there is a lot of other types of inflammatory reaction in younger prostates. So it's difficult. But I think the outcome of our results that we published, the proportion of cancers detected, it's fine. But we can't really answer that question until we see what happens with the men who did not have a biopsy, or the men who had a benign biopsy. What happens with them after 2 and 4 and 6 years? That will give us the answer. So we can only say what we found. We can't say whether we found the right cancers or not yet.
Okay, thank you. Joyce, I have a very last question, very provocative, of
very
course,
short.
Ola. So as the field is rapidly evolving and based also on the results of this round of invitation, what would you, if anything, change in the design of the study? Would you introduce other stratification, confirmatory PSA, maybe biomarker, or are you happy with this?
For the time being, I'm happy. With time, it would be fantastic to include a biomarker to reduce the proportion of men needing an MRI scan.
Great, thank you.
So Gianluca, Ola, thank you so much for your time. Very nice paper, very interesting discussion. So I would invite all our listeners, everybody watching or listening to our podcast, really go to this paper. It's very interesting. And thank you both for your time.
So for our second paper, we're switching gear completely to a topic that I don't think we cover enough, generally speaking, in GU oncology, and that's the topic of penile cancer. We're featuring a paper this month, which is specifically looking at the management of node-positive penile cancer. So this is a topic that we see in our cancer centre quite a few times a year, but I know in many urology practices this is a pretty rare setting, so it's great to see a big paper like this in European Urology that we can refer to as a management update. So as ever with these podcasts, we won't be diving in great detail into this paper, but we will have a quick overview and a really good discussion. So it's a great privilege to welcome first author Ashwin Sachdeva, who is a urologist and PCF Young Investigator at the Christie in Manchester. He's the lead author on this paper, and it's great to welcome you, Ashwin. And we're also joined by my colleague at European Urology, Dr. Sarah Sutka, who is a urologist at the Fred Hutch Cancer Center in Seattle and director of the SUO Fellowship Program there. And Sarah, of course, is an associate editor at European Urology and actually handled this paper. So welcome to you both.
Thanks so much for having us, Declan.
Ashwin, I'm going to start by asking you to give us a quick high-level overview of this paper and what you found, and then we'll hand over to Sarah to take you through a few questions.
Great, and thanks for the invitation, Declan, and thanks for publishing our paper, Sarah. It's really good to see penile cancer being highlighted in European Urology, as you mentioned. So as you will already be aware, penile cancer is extremely rare. It affects about 1 in 100,000 men, and outcomes for localized disease are reasonably good. However, in about 1 in 3 patients, penile cancer is already metastasized to the lymph nodes at the time of presentation, and this can have a significant impact on both mortality and patients' quality of life. So just to again put that into context, the survival for lymph node positive penile cancer is approximately 50% at 3 years, which goes down to about 30% at 5 years. And obviously the higher the nodal stage, so N3 disease being associated with even worse outcome. And just thinking through how we manage penile cancer, this is perhaps best considered in 2 parts: management of the primary tumor and management of the lymph nodes. And as part of this particular paper, which formed part of the process for developing the 2023 EAU and ASCO penile cancer guidelines, we undertook the systematic review of the clinical effectiveness of various approaches for managing lymph node metastatic penile cancer. And the primary outcome here that we were looking at was 5-year overall survival. So we screened about 3,500 abstracts and found just over 100 studies based on approximately 10,000 patients over the past 30 years. And as you can imagine, given the rarity of this condition, the majority of the studies were observational or case series, and only 2 randomized controlled trials were identified which had reported their outcomes. So the quality of the evidence base is reasonably poor. So coming to the key findings of what we can deduce from this pretty expansive but reasonably low quality evidence base, we know that surgical treatment remains the mainstay of treatment for the management of lymph node positive penile cancer, and early use of inguinal lymph node dissection is associated with much improved disease-specific survival. And there is, unfortunately, the flip side of it, which is the significant associated morbidity and the impact on patient quality of life. And so the EAU guidelines have had a particular focus on survivorship issues and the importance of counseling patients off these. And there have been attempts made through a number of different surgical techniques and approaches to try and improve or reduce this complication rate. Unresectable groin disease, however, requires multimodal therapy, particularly in N3 disease, when there could be bulky or fixed inguinal nodes. And in this particular setting, neoadjuvant chemotherapy should be considered. And adjuvant radiotherapy may be of benefit in N3 and perhaps in N2 disease. The other aspects to consider here really is the pelvic lymph node dissection, which is primarily a staging procedure, but may also improve overall survival in some cases. So putting this together, we have a reasonably poor evidence base, but the best so far in terms of summarizing the literature to help clinicians understand the various nuances of the studies which inform our current clinical decision-making and which were used to develop these updated 2023 EAU ASCO penile cancer guidelines.
Very good. Sarah, you handled this paper. You would have seen all its iterations going through. Please give us your thoughts and see what Ashwin can respond to. I'm sure you've got a few good questions for him.
Thanks, Declan. Well, Ashwin, I think when I saw this paper come across, I was excited because obviously penile cancer is an incredibly rare disease that I think even among urologic oncologists, really the management of complex penile cancer ends up getting fairly centralized. And so the experience that each individual provider has ends up being considerably diluted. That's where the guidelines are just so important, I think, in ensuring that we're managing these fairly complex patients at sort of the highest level. And I really appreciated the rigorous nature with which your team undertook the review. And I think also that the quality of the interpretation of the evidence was extremely helpful here. And I think it actually, systematic reviews are as good as the quality of evidence, but also they're in a really well done systematic review and meta-analysis, and this is where I appreciated this paper especially, will interpret the evidence in a cautious way and also sort of overlay the experience of the experts who are undertaking the evaluation. So I just kudos to you and your team for putting together, I think, what is a very thoughtful review of a complex literature that is heterogeneous in terms of its reporting, that has major knowledge gaps that persist, but that I would say also focuses on an incredibly vulnerable patient population, and therefore I think highlighting the imperative of providing high-level standardized care to these patients is critical. So that's just my 2 cents. I think that there were a couple of sort of really important controversies that were highlighted by your work, and also I just think that some critical points that as a community, we really need to recall, which first and foremost is the fact that even in the setting of clinical node negative disease, there's a substantial burden of micrometastatic of disease in penile cancer. So I would highlight that, and that's why surgical management of the groins is imperative. I think you also, this obviously sort of underscores the strength of the recommendations in the 2023 European clinical guidelines for how we manage penile cancer, specifically with respect to ensuring that we adequately stage the groins with either dynamic sentinel node biopsy and or just a templated dissection. I think I would love to hear you comment a little bit about what findings you thought were particularly surprising, if anything came up as you were doing the analysis. And then also, I'd love to hear you comment on the conflicting results regarding what your team identified in terms of the role for adjuvant radiation therapy in PN2 to 3 disease compared to what's previously been reported.
Well, thanks very much for those very glowing comments there, Sarah. And I must say that a lot of this was a big effort across a large team of people who played a very significant role in seeing this through. So it's quite difficult to answer some of those questions, really, because the evidence base, like you said, is so heterogeneous. With regards to your particular comment about the adjuvant radiotherapy, again, we found that there was a particular paper suggesting that adjuvant radiotherapy might be more efficacious in HPV positive penile cancers as opposed to HPV negative penile cancers, and that in itself is a controversy. We know from multiple studies that the results are conflicting in terms of what does HPV itself have an impact on outcomes, or does this select for perhaps a more indolent disease course. So the heterogeneity in the disease biology itself and its interplay with therapies makes it difficult to interpret results. You mentioned centralization of care, and it's important to realize that, for instance, from the paper recently out from the NKI, which suggested that the incidence of penile cancer is slowly rising, and with greater centralization, such as in Netherlands, in Belgium, in the Nordic countries, and in the UK, the experience of urologists in such specialist centers to deal with these rare cases in a multidisciplinary team setting with oncologists who have expertise in in delivering radiotherapy and chemotherapy to these patients in a much more selected manner has contributed to some degree to improve survival outcomes in these patients. I may not have fully answered your question, but I think my hands are tied by the very heterogeneous nature of studies with small sample sizes that we can rely on. Really highlighting the need for more collaboration in multi-institutional studies, both prospectively and also in a randomized setting, to try and answer these particular questions more reliably.
I couldn't agree with you more. I mean, the fact that there were only 2 randomized controlled trials that you could draw on, and obviously the tricky bit with a randomized controlled trial is often the most effective trial structure will have a very focused question. The problem is, of course, we have a rare disease that in terms of sort of individual accrual, it presents a number of sort of, I would say, trial design challenges. Obviously, and you highlight in the discussion the impact trial, which I think is a really important and very thoughtfully designed trial that's attempting to overcome a lot of the limitations that are sort of germane to the biology of the disease. Can you just in the process of working through this, did you have any thoughts about sort of critical trial design, sort of strategic considerations that we should be thinking about? What are the knowledge gaps that we should be sort of tackling here? And can you think of anything that might pragmatically allow us to answer those questions in a reasonable amount of time? Because obviously that's a big, tricky sort of, it's a thistly question in the field.
Absolutely. And it really comes down to a few key questions in terms of timing of therapies, selection of therapies, and selection of the appropriate patients for those therapies. And I go back to my previous point in terms of centralization of care and collaboration between different institutions to develop that expertise as a community, but also start to identify patients prospectively for recruitment to such trials. The impact trial, though, hasn't yet reported its primary outcome, has been successful in up to last year. I think recruited about 143 patients, which really gives us a bit of hope that there is feasibility of recruiting to such a study. And if we were to prospectively follow up some of these patients and understand their changes in biology understand the changes in their outcomes in response to therapies in a more concerted manner in a multi-institutional collaborative study, we may start to understand how we can use this information to design studies, such as if we understand whether HPV does truly impact response to adjuvant radiotherapy, we may consider making a stratified trial design. And if we can identify features which might be predictive of toxicities to chemotherapies, TIP, which is the commonest chemotherapy regimen used in an advanced penile cancer setting, is extremely toxic. But if we can identify patients who are less likely to experience those toxicities, we may be able to use that again to better select those patients for therapy.
Yeah, I think that's a critical point. I mean, obviously identifying sort of treatment sequencing and then identifying those patients that are more or less likely to experience toxicity with treatment intensification, and obviously selecting patients who are more likely to benefit and less likely to be harmed by the therapies that we request or that we sort of recommend is critical. The last sort of question that it's always on my mind in penile cancer, because obviously the therapies for penile cancer across the board are incredibly challenging for our patients to go through. It's a disease that's associated with a substantial amount of impact on quality of life. It's a particularly in terms of risk factors for the disease, we know that it's a fairly vulnerable patient population, many of whom their outcomes are also influenced by social determinants of health. We really don't have a lot of data about that in the penile cancer sphere. And I think that there's a particular glut, as your team identified, in terms of the sort of the data regarding how our therapies impact patient-reported outcomes. So can you talk just a little bit about sort of if you had unlimited resources and opportunity to study in this field. So sort of what PRO how would you sort of seek to incorporate PROs into study design? And also, do you think that do you have any general recommendations for those of us who do treat penile cancer, kind of how we should be focusing on, I think, data collection, but also obviously supportive and adjuvant services for these patients?
Absolutely. So complication rates for following inguinal lymph node dissection are reasonably high. About 50% of patients will either sustain a wound complication, which could be wound breakdown, infection, necrosis, or a lymphatic complication such as a lymphocele or lymphedema. And this really stresses the need for us focusing on survivorship issues, as we have done with patient involvement in the development of the latest EAU guidelines, and unfortunately, there is very little data on post-treatment quality of life that's objectively measured in a consistent manner across studies. At our center, we've been looking at incorporating electronic patient-reported outcome measures, which patients complete on a regular basis prior to their visit to the hospital, and this sort of an approach provides an insight into perhaps mental health issues, which we're not so good at necessarily ascertaining during a clinic visit. The other thing to consider here perhaps is that there are a number of improvements in the surgical approach itself, that perhaps using a modified lymphadenectomy approach, such as fascial sparing, saphenous venous sparing, perhaps not performing a sartorius muscle transposition. All of these steps have been demonstrated to reduce the morbidity of the procedure itself. And there is a greater drive, and we sought to compile the relevant evidence to show whether minimally invasive surgery here, either Valent or Reveal, using either laparoscopic or robotic approaches, may further help reduce these complications. Secondly, just coming to the other really important issue you mentioned regarding socioeconomic determinants of health, and this is certainly something we see in our practice of there being a greater proportion of patients from more deprived areas presenting late with penile cancer. And this really needs a public health based approach where we try and raise awareness of penile cancer, as we hope that today's podcast would help support, and also develop approaches and campaigns for early detection of disease, where we really need to target these populations in deprived areas and make them aware, and seek and consider interventions to improve their access to healthcare services.
Wonderful.
So it's a challenging topic.
It is challenging, but rare cancers like this, and your systematic review shows it very nicely. 2 randomized trials in 30 years are chronically underfunded. There's almost no commercial interest, no commercial drivers. Research is very expensive, especially prospective randomized research, and that's probably not going to change. So in the meantime, I think having really high quality systematic reviews is important to help guide clinicians and the community about managing these patients. And congratulations on the paper. And Sarah, all your questions were exactly what me and many other listeners, I'm sure, are thinking as you approach these patients. So thank you very much as well for handling this paper and for your discussion. And you're going to be joining us later in the podcast for a bit of a chat about yourself and your role at European Urology. But thank you again for joining us for this discussion, Ashwin and Sarah.
Thank you, Dan.
So Sarah has popped back on the podcast to join us for a few minutes in our irregular Meet the Editor segment. So I know many of you listeners and viewers do enjoy hearing a little bit about what drives the back end of European Urology. And it's really nice to meet our senior editors. Sarah was an associate editor in the last regime before we changed over editors just a few months ago. And she stayed on. We're very pleased because it's great not to change the whole editorial team. And it's great you decided to stay on, Sarah. So I wanted to ask you, first of all, a little bit about yourself and your job at Fred Hutch. You're very much a GU surgeon, oncologic surgeon, and also a bit about European urology. So tell us a bit about your day-to-day job or what got you into your field of interest at Fred Hutch.
Well, thanks for having me, Declan. I'm a urologic oncologist. I am fellowship trained, and my clinical practice specializes in the management of complex kidney and bladder cancer surgery, but also I have a specific focus and interest in the management of advanced testis cancer. And I think that I tell people I have my dream job. I work with some phenomenal people at Fred Hutch. I'm lucky to be a part of a really deep multidisciplinary team that is obviously very committed to the care of patients with advanced GU malignancies. And I've been really fortunate. I've been there for about 6 years now. Really, really fortunate from a clinical perspective to sort of grow my practice. But from a research perspective, I'm getting to study things that I've always wanted to study that I was worried I might not ever have the chance to kind of delve into, just because they tend to be topics that are a little bit further afield. But I think my real kind of clinical passion is trying to figure out how we can do a better job of putting some data on how we risk stratify patients and establish candidacy for therapy. I sort of started with a deep dive into things like body composition and nutrition, and then got into frailty. And now I'm really focusing on kind of comprehensive assessments, leveraging geriatric assessments. And that's led me, to you move from kind of problem to solution. So we've moved from how do we define the problem and how do we kind of establish a personalized assessment of kind of risk and reserve or resilience in patients to understand candidacy for therapy, and then how do we move the needle on that? So we're getting into doing pragmatic rehabilitation trials, and that's been really, really fun. So yeah, I'm a pretty lucky surgeon, I would say.
Well, I remember when you came down here to Australia 2 years ago as international faculty for our national meeting, you were a huge hit, but everybody knows you do a lot of very big surgery, but you spoke a lot in that conference about other things that go around the patient journey, patient selection, prehab, rehab, ERAS, all that sort of stuff. And I heard young urologists here in Australia saying that I really liked what Dr. Sutka said about that, because we sometimes think it's all about big surgery, especially if you want to do urologic oncology like you do. But you open their minds to the idea that you need to be across all of the things that really improve a patient's journey in cancer. So do you think that's an important thing we need to get across to trainees? I know you run the SUO fellowship program at Fred Hutch, but I think it is in our cancer centre. We try and say, don't focus on a device or a procedure because you don't want to do robotic whatever. Focus on a disease area. How can I make things better for my GU oncology patients? Not just how can I do one operation?
Well, I couldn't agree more. I mean, it's the old adage, just because we can doesn't mean we should. But the question of should is actually super complicated, right? Like, it's not just disease process equals treatment. If you think about like all the debates we're having in our field right now, they all focus on patient selection, treatment sequencing, and really trying to making sure that we're sort of appropriately treatment intensifying, but also I would say there's a big push to kind of back it off. Like, if we can de-escalate therapy and reduce therapeutic burden, think about like impact on quality of life, think about impact on financial toxicity. I mean, all that stuff has to be considered. I mean, we're physicians first and foremost, we're not technicians. So I have really kind of enjoyed thinking a lot about, especially recently, I've been trying to learn from our colleagues in geriatrics, actually, and think really intensively about sort of novel outcomes for clinical trial design, how we can do a better job of understanding the outcomes that matter to patients. So moving beyond, I think efficacy will always be first and foremost in our trials, but we have to be thinking about patient-centric outcomes in terms of things like impact on quality of life, impact on independence, thinking about things like recovery trajectories and how to accelerate those. So yeah, it's been really fun to kind of try to take a very scientific lens to a lot of concepts that have not had a lot of data behind them traditionally, but we now have ways to measure things like resilience, neurocognitive frailty, recovery trajectories in general, patient-reported quality of life. We just have to collect the data. And then the other sort of thing that I've been thinking a lot about are and this is a sidebar, but I mentioned to you I was writing a grant this morning, and so this is what I'm thinking about right now. But I think a lot about how we can sort of reduce treatment toxicity and sort of symptom burden. And one of the really great things about the place I work is there's a really big, for example, integrative and complementary and alternative therapy team. And so in addition to thinking about how we can do a good job of helping our patients access exercise and nutrition, we actually just finished a trial not too long ago looking at acupuncture in bladder cancer patients and thinking about how we can use these other therapies to maybe reduce the need for things like opiates, how we can help patients get through therapy better. So I think, our field is rich in questions. I think there's a lot of unknowns in terms of how we can best improve quality of life for our patients. But at the end of the day, the biggest question we all have to ask ourselves always is, patient in front of us, what can I offer the patient? And then ask the patient, well, what does a successful outcome look like to you? And then we got to match that treatment to that outcome. And that outcome's not always going to be necessarily sort of length of life. It may be quality of life, or it may be days out of the hospital, things like that. And having that awareness, I think, is super important.
Totally agree. And your point earlier about de-escalation as a strategy almost goes against the grain of a lot of geo-oncology, which is escalation, combination of this and that and the other increasingly more expensive things. And so it's one of my missions as well, is trying to say, can we do a bit less rather than a bit more? And especially if we put the quality of life and prioritization of patients at the start. And it's getting so expensive as well. I think that whole financial distress thing, would you rather keep that extra piece of land on your farm so you can hand it on to your kids, or do you have to sell it to fund that extremely expensive treatment that might buy you an extra month of life, etc., etc. Anyway, you and I have talked about that before, and we could do again. But the last question we wanted to ask, of course, is you are an associate editor. You handle a lot of papers at the top urology journal, and listeners out there who might think, oh, how come I've got so many straight rejects like me? I have to say, I'm speaking from personal experience. What is it when you see a paper coming across your desk that Alberto Briganti has sent to you, because it's got past Briganti at least, as an associate editor triaging papers? What are the things that make you think, yep, as I go down through it, I'm going to send it out for review, versus nope, straight reject? I don't want to waste the time of our reviewers. Just a few little tips.
Well, I'll be honest. I think I can talk to Dr. Briganti about this, but I have a very, I don't send out a lot of straight rejects, largely because I want to see the papers that we get, first and foremost, are generally of a very high quality. So if something's going to be a straight reject, it's really because it would actually do better, reach more readers in who that work is going to be more impactful for if it goes to a different journal. So I think a lot of times if something's a straight reject, it's largely because it's the wrong audience. And it will have a greater impact going to maybe a more subspecialty journal, or sometimes a lot of the really high-level translational work will actually have more impact if it goes to a more specific journal.
Yep.
But the things that I'm really looking for, and that we're all looking for, obviously, in terms of priority, are how is this going to move the needle on what we do? A lot of the work we're trying to sort of focus on and highlight and put in the journal is the kind of work that's actually going to change clinical practice, that's going to change our understanding of the biology of the disease in a way that modifies how we think about the need for treatment intensification or de-escalation or treatment sequencing. And then, of course, there are very sort of strict quality bars that we're also looking for. So I think I get excited about a lot of the sort of novel work that I'm seeing in terms of some of the translational work, spatial transcriptomics and things like that are really going to move the needle on how we understand the way that these diseases progress. They're going to help us understand things like resistance mechanisms. They're going to help us understand selection criteria for specific therapeutics as our sort of our list of therapeutics, our options increase. But obviously with novel and oftentimes pilot studies, we also have to think about where the samples come from, the representation, the sort of external validity of the work. And so it is a high bar, but I do actually always try really hard to make sure I give work a fair shake. And there are a lot of things that are beyond my area of expertise based on, I told you what I'm interested in. That's very different from a lot of the papers that I read. So I make sure that when I send them out for review, I'm sending them to people who can appreciate, who are really sort of experts in that field and can give it a fair evaluation so that we can really understand, what are the papers that are going to move the mark and what are the papers that might land better somewhere else.
Fantastic. I hope that's been helpful to viewers and listeners. And you can catch up with Sarah and many of the other members of our editorial team at European Urology next month. If you're listening to this in March, there's a lot of European Urology activity. We've got a great big stand in the trade area. We'll all be hanging around there quite a bit. So please do come along, come to the European Urology writing course. And there's a pile of courses that faculty like Sarah are involved with. Actually, we were chatting earlier, Sarah, you're involved in a few nice things. You've got a debate on triplet therapy in renal cell carcinoma. That's going to be good. That'll be feisty. You're teaching on the ERAS course, I think, the ESU ERAS course. And what else? You've got a couple of other things. You're busy.
And it's going to be a busy meeting. Another one of the controversies in bladder cancer debates. So it's always fun to be part of all of those. But I think the EAU is just such a fantastic meeting. I'm very excited about our ERAS course. With Drs. Walsh and Fankhauser. I think that's going to be, it's been really nice to see how ERAS has become so kind of integrated into all of our clinical pathways in GU oncology. And we're really going to focus on that. It's not just in bladder cancer that we're looking at. We're going to kind of break ERAS down into its component pieces and think about how we can plug and play different pieces of ERAS across the disease spaces. And then also think about how to make it work in each other's institutions, because obviously a big part of ERAS is kind of the implementation science of it. And how do you take what is really, it's a little bit of sort of a laundry list of options. How do you figure out what are the pieces of it that are going to be most successful in your own institution so that you can actually drive the most significant benefit from it. So I'm really excited for that. So it's going to be great. I'm looking forward to seeing everyone in Paris.
Me too. Great. Sarah, thank you so much for joining us.
Yeah, my pleasure. Thanks, Declan.
So finally, for our other very popular segment on the podcast, where we ask one of our senior trainees to have a look around what else caught their eye in the journal, apart from the two papers we've already highlighted. I'm very happy to welcome Dr. Eduardo Felicia. Eduardo is a urology trainee. He's a fourth-year resident in Lisbon, in Portugal, and he very enthusiastically reached out to us when we put out a call to say, if you're interested in joining the podcast to cover this segment, while Nikita is off on maternity leave, we'd love to hear from you. So Eduardo, thank you very much for reaching out to us and thank you for joining us.
Thank you, Declan, and thank you, Joyce. I hope that my perspectives will reach our discussion and engage our listeners. Thank you so much.
No problem at all. So tell us a little bit about what's it like being a urology trainee in Portugal?
Well, I believe that's same worldwide. It is a difficult thing, the residency, but I think I'll make it.
Yeah, and you're very enthusiastic members of the EAU and supporters of the journal, I know. I have lots of Portuguese friends, and I must say I'm looking forward to catching up with many of you at the EAU meeting next month. It is a big meeting for the Portuguese urologic community, I think.
Yeah, it is. I'll be there.
That's great. And do you listen to podcasts? Are you an enthusiast?
Yeah, I listen to the European Urology Podcast. As I live about 40 minutes from my work, I started to listening to the podcast so I can make the time valuable. So it is a kind of thing that I do often, quite often.
Yeah, same for me. I'm a 40-minute ride to work on my bicycle when I cycle to work. So I always load up a couple of podcasts. It's a nice way of passing the commute to work, or when you're out for some exercise or cooking in the kitchen, I always stick on a podcast. So yeah, well, good. You've been having a look at what else has gone on in the March edition of European Urology. So tell us, what else caught your eye?
So the first paper that I chose, I believe it's from a well-known person from this podcast. It is from Nikita, and it's about artificial intelligence and the social media. I'm sure that we all agree that social media is a part and a major part of our society. I might even say that it is a really, maybe a too deep part of our society. We live really profound in the social media. So Nikita highlights the potential uses and the potential dangers about using artificial intelligence in social media. We can use also artificial intelligence is an emerging role in our society. So it has the power to automate our tasks, like scheduling appointments. And it has also the potential to content creation, monitoring trends. And I believe that also Nikita highlights a thing that it was like, what if you could use artificial intelligence so you could access the mental health status of our cancer survivors? It would be an useful use. However, it also creates some of the ethical dilemmas and legal problems. And I think that we as a society, and also more specifically as urologists, we should also discuss and reflect. Besides the artificial intelligence is so rapidly evolving, we might not have the time to think and to reflect. But I congratulate Nikita for her work, and it is a really nice paper to read and to reflect, especially for the younger generation of urologists, as we will have to deal with artificial intelligence and social media, certainly, so we may think about it.
Yeah, I totally agree. And last month in the February edition of the journal, we also highlighted an AI paper on ChatGPT from Giovanni Cacciamani and co. So yeah, this is an important area for the journal to keep on top of as well. So we will welcome high quality submissions on this area, because it's important for us urologists, the urologic community, anyone working in urologic healthcare, to keep abreast of these changes. We can use them. These are tools that I find useful, I must say, Eduardo, for patient information leaflets, high-level overviews of topics. Just instead of having a blank sheet of paper in front of you, I've got better at using prompts to create that and to create images. I've recently been creating a series of patient information videos with my colleague Renu Epen for GUcast. So we've been using both ChatGPT to create basic script, and we've also been using ChatGPT with DALL-E to create as kind of a uniform set of images where we can illustrate conditions. So I agree. That's a good one. We'll put a link in the show notes. What else caught your eye?
What else caught my eye? I chose the article that I think it's fascinating about circulating tumor DNA to identify muscle-invasive and non-organ confined upper tract urothelial carcinoma. It is a work done by Husler and Dr. Lee. And we all know that it's really difficult to clinical stage UTUC due to anatomical reasons, and that we also know, and Joyce knows the best, that uteroscopic tumor biopsies under stage UTUC quite often. So what this study tried to do was to pre-surgically evaluate the cell-free DNA plasma, and to see if if we could use this cell DNA to predict the muscle invasiveness and the non-confined, comparing to the non-muscle invasive. So what they've come across to conclude was that a significant higher median number of alterations were observed in the plasma of muscle invasive and non-organ confined versus the non-muscle invasive patients, with a median of 3 versus 0 variants. It also, it's important to know that the detection of at least 2 panel-based molecular alterations in the ctDNA yields 71% of sensitivity and 94% of specificity to predict invasive disease, with an AUC of 0.92. I believe that these results are quite promising, as the clinical normograms only achieve like 40-50% of sensitivity. The authors say and conclude that the circulating DNA appears to be strongly prognostic for PFS and CSS. So I believe that given the potential understaging of UTUC with the current diagnostic methods that we have as a tools to guide ourselves, and the risk of rendering patients to non-being eligible for neoadjuvant therapies due to the surgery, I believe that is really good to know that there are new ways of creating better ways to predict the muscle invasiveness and the non-organ confinement of the UTUC.
Excellent, and thereby allowing us to tailor our management approaches for these patients, because those muscle invasive and locally advanced ones, of course, are the ones with poor outcomes. So I think we are all excited about the liquid biopsy era. We've been on the edge of it for a few years now, and we still haven't got to the point of it breaking through into clinical practice. But I agree, this is a very nice paper. And your final paper that caught your eye, I know this paper.
Yeah, you know that paper. It's the lutectomy trial. So we know that there is known neoadjuvant treatment for the prostate localized cancer that has succeeded, but the Australian team, and I congratulate you, tried to study the lutetium PSMA to the high risk carcinoma of prostate cancer. So this is a trial phase 1, phase 2 of using neoadjuvant lutetium PSMA in high risk localized prostate cancer. The objectives of this trial are to evaluate the perioperative safety and dosimetry of neoadjuvant lutetium. So the primary endpoint was the tumor radiation absorbed dose. You also evaluated other things like the surgical safety. And one of the things that I found really, really interesting was that unlike salvage therapy, the surgery went without surrounding tissue alterations. Maybe this is due to the short time between the lutetium and the surgery, but there are a lot of other things that happen with lutetium that don't happen with other kinds of radiotherapy. Another intriguing finding was that the radiation was delivered almost as double to the lymph nodes comparing to the prostate gland. And the conclusion is that the lutetium PSMA is safe and delivers targeted doses of radiation. I believe this is really, really intriguing because it is a new way of looking to the prostate cancer, and maybe why not to combine both radioligand therapy and surgery as to improve our outcomes, as we know that over almost 50% of a high-risk population will occur to biochemical recurrence.
Great. Thank you for picking that nice paper, the lutectomy trial. We ran that during COVID, and yeah, it was very successful, really. We wanted to move away from just using castration as a backbone for a neoadjuvant study, which is what every neoadjuvant study has done, and added in chemo or AR pathway inhibitors. And while that still has some merit and may prove to be successful, there still is no standard of care neoadjuvant approach. And because radioligand therapy works very well in very advanced cancer and is very well tolerated, it does make sense to bring it forward. And my conclusion on lutectomy is that, yep, we should explore this more. We should give higher doses of lutetium. We should give more cycles. We should wait a bit longer. We should do a randomized trial. And all those things are in play. That's very much on our radar for one of the big projects we'll be running in the next year or so. And if you want to hear more about lutectomy, we'll put a link in the show notes, but we dedicated a full episode of GUcast, our main podcast, which supports this podcast, to lutectomy. So if that's the topic that you're interested in, you can go and have a good listen to first author Renu Epen and my colleague Michael Hoffman talk about that. Eduardo, thank you so much for that. I presume you will be at EAU in April yourself?
Yeah, I'm sure I'll be.
Very good. Well, we look forward to seeing you, and thank you very much for joining us on this segment of the podcast. You did a fantastic job.
Thank you. Thank you so much. I'll meet you there.
Thank you.
Thank you. Thank you, Declan.
So that's all we have time for in this, the March edition of the European Urology Podcast. Thank you very much for listening. Please do subscribe, rate us, review us if you're feeling generous, and we will be back next month with another edition of highlights from the world's leading urology journal, European Urology. If any of you are attending the EAU annual meeting in April in Paris, please do come and say hello. The European Urology editorial team, including myself and Joyce Bard, my co-host on the podcast, will be around the EAU. We'll be hanging around the European Urology stand in the trade area, so please do come and say hello. But for now, that's all we've got time for. Thank you again.